We are live. Well, good morning and welcome to Grand Rounds. Got a fun one today because we've got a fellow that I can't remember when I first met you, Howard, because it was on your first trip here.
Yeah, 2.5 years ago.
2.5 years ago, but it took us 2 years. He's been here a little while. 2 years to get up here, but it's a pleasure to introduce Dr. Howard Pride this morning. Howard. Dr. Pride is a board-certified dermatologist who's been practicing dermatology since 1993. He was at Geisinger in Pennsylvania, where he served as chair of the dermatology department for 6 years, and currently with VTC, Virginia Tech Carilion Dermatology here in Roanoke. He's co-author of a textbook on pediatric dermatology, numerous peer-reviewed articles and book chapters. In addition, he's been the camp director of Camp Discovery in Pennsylvania, formerly Camp Horizon. It was a camp for children with chronic skin diseases, or I assume it still is a clinic for children with chronic skin diseases, since its inception in '95, and he's been chairman of the American Academy of Dermatology's Camp Discovery. He received presidential citations for the AAD's Golden Triangle Award for his work with the camp, and was also past president for the Society of Pediatric Dermatology. Please just give me pleasure to introduce Howard for giving us a talk on that. If you're in the Tanglewood area, come on down. We got some biscuits and some cinnamon rolls. Otherwise, it's going to the staff afterwards. Anyway, let's see what happens today.
The introduction. I presume a lot of you are online, so welcome to you, and get up your email and listen to what's going on here. I really appreciate the introduction and the ability to speak to all of you. I'm a dermatologist by profession, but I have to say my heart really is in pediatrics. My kinship with pediatricians, I think, is much closer, as long as it stays in this room, than I think with some of my colleagues in dermatology. I don't need to tell you, I'm preaching to the choir that pediatricians are pretty special people, and I really love my colleagues in pediatric dermatology and pediatrics. So I'm really relishing this time to start to get to know all of you. I know I've been seeing some of your patients, but to see you face to face, to do noon conference with the residents is really special as well. So thanks for the invitation. I have no conflicts of interest. It doesn't mean I'm unopinionated, and you'll see that a bit especially when we start talking about some of the newer pharmaceuticals, but I don't have any conflicts of interest at all. We've got a pretty aggressive and ambitious agenda here. So one of the nice things about a talk like this is it just follows my stream of consciousness. There are things that are new to me, things recent in the literature, things that I think are not new but perhaps are new to you, and hopefully things that you'll take back to the clinic and be able to use right away. So I'll be quoting some studies that actually go back to the 1990s, and you think, man, this is like 30 years ago. What's new about that? But I think there'll be some pearls here that'll be interesting to you. But we've got a lot to go through. Again, if we get caught short on time, this is not a talk with a particular theme. I can stop pretty much any time I need to. So when I start seeing a glazed look on everybody's eyes, then I know I've gone too far. Those of you online, I won't be able to use that cue. So let me introduce myself a little bit. I grew up in Rhode Island, so I'm an unapologetic Red Sox fan, and unfortunately a Patriots fan as well. And my kids will never let me hear the end of it, but every now and then my R's get dropped. So PETA, sit over here. Every now and then that comes out. Hey, I went to Brown. I was a water polo player, but really my passion is open water swimming. I live on Smith Mountain Lake. If any of you are on the lake vacationing, if you see a guy swimming out in the open water with a little yellow floaty behind him that his wife makes him wear, please keep your distance. I'm not eager to get run over. Went to medical school at University of Vermont. Did all my training, so I did med-peds at Geisinger, then into dermatology, 7 years a resident, and boarded actually in 4 different specialties. Which my wife will not let me forget as well. And my career has been in central Pennsylvania at Geisinger, but I'm just thrilled to be here. I love living on the lake. I love working here in Roanoke, and I've really loved the relationships that we've started to build here. So far, we'll talk a little bit about access in pediatric dermatology in general as kind of an introduction to what's new. So far, access is pretty good. Now, I was just in Honduras a couple of weeks ago. I'm heading to like 2 weeks in Vietnam coming up in April, and I only work 3 days a week. So I've got a little bit of a compressed schedule right now. But I think you'll find that if you refer somebody to dermatology, they're getting in pretty quick for pediatrics. So I'm really proud of that, and I'm hoping that that's something we can continue. I've got a wonderful nurse, Courtney, that works with me, and when she's called, she knows I don't give her a hard time if I'm double booked, if I'm working over lunch, if I had somebody on late. So somebody needs to be seen, they definitely will be seen. But it's not true across the country. A pediatric specialist, pediatric dermatology is third in line for the most difficult specialty to get in. So something that might be new to you and might be of interest is to help with access in pediatric dermatology. There are a number of programs that are looking into a special tract for trained pediatricians to go into dermatology. And there are 15 programs that actually are showing some interest in this. This is brand spanking new. Now, it's with some expectation that you're going to go through the program and come out of pediatric dermatologist and not be injecting Botox and doing fillers and that sort of thing. But for those of you that might have thought, boy, it's impossible to get into dermatology. I've already done a residency. No one's going to take somebody who's done a residency before. Actually, this is a track that might be appealing to some people. There's some things that we did at Geisinger that were fairly innovative that I think have some generalizability to them as well to other specialties that are hard to get into, peds psych, peds room, and that sort of thing. So for 1 year, one of our chief pediatric residents spent a year with me, spent a certain percentage of her time with the blessing of the chair of pediatrics. In clinic, we did a lot of didactic things, and she stayed on staff, and now 50% of her practice is doing pediatric dermatology with us as backup. And to this day, I still meet with her like once a month, and we'll go over cases and that sort of thing. As I knew I was leaving Geisinger, we set up a course that was about 10 weeks long, or 10 months long, meeting once a month with interested pediatricians. And about 25 general pediatricians took me up on this and designed a really nice curriculum hitting the really key features of a pediatric dermatology practice. Now, it's not as in-depth as a fellowship, of course, but at least the most common things that come in, I think we gave good training. And of those 5 of them, spent extra time with me, clinic shadowing and such as well. So they're all back at Geisinger now, taking some of the strain off of not having a pediatric dermatologist in central Pennsylvania at the moment. And at Geisinger, the e-consults we call Ask-A-Docs. And I think this is a really good way of kind of getting your patient's foot in the door. Our residents screen them here. I had to do them all at Geisinger. I would have loved to have had residents doing these. But we got to a point where we were doing like 800 of these a year of just kind of screening cases with photographs and saying, this has definitely got to come in, and expediting it. This doesn't need to be seen. You can do it this way. So as access becomes a little bit tighter in pediatric dermatology, taking advantage of e-consults, I think is really helpful as well. All right, so let's talk a little bit clinically. When you come right down to it, actually, most of the things with hemangiomas are not all that new. But we'll talk a little bit about hemangiomas. It's kind of incredible to me that once upon a time, I think, a little bit before I started my training, basically, if it was red on a patient's skin, it was called a hemangioma. And now we've got a much more sophisticated way of looking at vascular lesions, basically categorizing them as vascular tumors, which is hemangiomas and its variants, and vascular malformations, port wine stain venous malformations. So a little bit more sophisticated way of looking at it. But we're also recognizing that in the vascular tumor domain, that there are some subtleties that I think might be a little bit new to you. Beta blockers is not brand new. When I start talking about propranolol, I doubt if that's going to be shocking to anybody for treating hemangiomas. That's been the norm for about 18 years or so. And then the recognition of some associated abnormalities. So we think of syndromic vascular abnormalities, port wine stains like Sturge-Weber and triple trenin A and those sorts of things. but hemangiomas have some syndromic associations as well. And where this comes into play is if you're a hospitalist or a resident working in the hospital, from time to time, dermatology is going to call you and say, I've got somebody I need to bring in, and this is the reason behind that. Now, I know you can't read this, but what I want to introduce you to is the concept of an infantile hemangioma referral score. And this was published in Pediatrics a few years back. You're never going to remember where to look at it, and if I put a link, it'll be gone. If you just simply Google infantile hemangioma referral score, infantile hemangioma score, you will come up with this. And this is kind of the sheet that you'll get. And it's as simple as check, 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 check. If you get a certain score, that should be seen. If it's below a certain score, it can be followed. So referral, what I would say is probably, rather than refer, put in an e-consult, let us look at the pictures, and we can usually say, oh, you're fine with that, just follow it, or I'm going to get this in real quick. But for the most part, these aren't decisions that you want languishing for month after month, because you've got a window of opportunity of treating hemangiomas, and you've got to pounce all over that. So again, you're not going to, if I put a link up, it's going to be gone. If you just simply remember, Google infantile hemangioma referral score, you'll come up with that. And it's a pretty nice algorithmic way of whether this is somebody that should be seen or somebody that you can follow. Kind of a variant of hemangiomas, not there at birth, so it's behaving like a hemangioma. It's coming on, it's growing a little bit, but then just kind of sits tight like this. So a variant that we call a minimal growth hemangioma, well, it used to be called an abortive hemangioma. So worrisome in that it's segmental, but doesn't really turn out to be very much. These kind of early hemangiomas, just pallor like down below, or just barely showing itself, what we'll tend to call precursor lesions. And these fool me all the time. So that might be something that's new to you. I've had these where I've called them nevus anemicus or nevus depigmentosus or some kind of term like that, honing in on the hypopigmentation, when in fact you can kind of see a little bit of vascularity in the middle of that. Hemangioma that's there at birth, it's not the way that's supposed to go. Doesn't go through a growing phase, doesn't go through an involutional phase, but it's clearly hemangiomatous. And I don't usually biopsy these, but if you biopsy them, it would be read as a hemangioma vascular tumor as opposed to a vascular malformation, but it doesn't behave that way. So a non-involuting congenital hemangioma. Why recognize that? Because you're not going to be able to tell a parent that by 5 years of age this is going to be gone and they're going to have a great cosmetic outcome. So unfortunately, the only real treatment for that, propranolol is not going to work, medical treatment's not going to work, is going to be to surgically remove it, which is not always easy to do. Another example here. Looks hemangiomatous, but it's there right at birth, doesn't grow, doesn't shrink. On the opposite end is something that looks very much the same, but within like 4 months has deflated like somebody put a pin into a balloon way sooner than any hemangioma should disappear. Rapidly involuting in this case, so a rapidly involuting congenital hemangioma. So this is a patient that was in the hospital just born 2 months ago. So there might be somebody either online or in the audience that took care of this little girl. I have her mom's permission to show the picture to all of you. Exactly that morphology in there right at birth. Now this is only at like 6 weeks of age, so it's too soon to show that it's going to be going away quickly or that it's going to persist. So until some time goes by, I'm not going to know which it is. I've got a sense that this is going to be a rapidly involuting congenital hemangioma and then it's going to have a nice outcome. And then there's sort of this halfway in between. It's there at birth, it's a congenital hemangioma, it has that same look, kind of pallor around the edge and kind of a telangiectatic component to it. And it goes away, but only partially goes away. So a new term is pitch, partially involuting congenital hemangioma. So these variants that you might not have been aware of hemangiomas either don't disappear way faster than what you ordinarily would think, or only partially disappear. Casabat-Merritt, I'm sure you've heard. When I was a resident, Casabat-Merritt was a consumptive coagulopathy associated with a congenital or with a infantile hemangioma. In fact, now we know that these are different vascular tumors. These are more aggressive kaposiform hemangioma, and thelioma or tufted angiomas, a whole different beast. So So this is not going to be like a propranolol thing. These are much, much more complicated patients with a fairly high mortality. Unfortunately, it's fairly uncommon. Then we talked a little bit about syndromic association. So this is not a port wine stain. Easy to mistake, but bright redder color, not there at birth, kind of appears and eventually proliferates. And this one proliferated terribly. But what's the worry with that distribution? It's not the things that go along with a port wine stain Serge-Weber syndrome. This is kind of what we think of as faces syndrome. And this is where all of you get involved with my patient. So that patient comes in, I'm going to be on the phone within 10 minutes with the hospital saying, I've got somebody I need to bring in. Because these are associations with faces syndrome, particularly posterior fossa and brain malformations and vascular malformations that go along with this. So I'm not going to start somebody on propranolol if they've got a critical anastomosis of their carotid artery, for instance. So on the phone, I say, I've got somebody I need to bring in. We need an MRI, we need an MRA, we need cardiology to do an echo and ophthalmology to look at their eyes. And there's just no way to coordinate that as an outpatient. Yes?
So on faces syndrome, the hemangiomas of the cervicofacial area, there are a lot of hemangiomas that happen. They're more segmental.
That's exactly the word, yeah. So focal versus segmental makes a huge difference in terms of underlying associations with hemangiomas. So that's a no-brainer, what I showed you a picture of. Hugely segmental, a little small one like I showed at the very introduction, focal. But they do blend together, and there's some judgment of this, of who needs to be worked up and who's not. That was a pretty easy illustration there, but that's a really great question. And then this is more lumbosacral. So a little less urgency than, say, somebody I've got to get on propranolol and I'm worried about a critical stenosis. But this is a syndromic sort of association you might have heard of. The lumbar sort of like clicks a little bit because sort of in the lumbar area. But you're mostly worried about urogenital abnormalities. They have a tremendous tendency to ulcerate, but particularly spinal abnormalities with this. So I've had a few that I've had to share with neurosurgery. Generally, they're coming in young enough where you can get ultrasound and look at that, and you spare them the MRI. But if they're old enough, have to get MRI on this. All right, that's vascular things. That was a little bit of a whirlwind, but questions on anything there so far? I don't need to tell you that our patient population is becoming a little bit huger. And if you just take numbers across the United States, the incidence of obesity has tripled since the 1970s. We're seeing it in our particularly adolescent, but discouragingly even pre-adolescent patients, to a point where, as of 2023, 1 in 5 children was obese and accounting for almost 15 million children nationwide. So as a result of that, there are a fair amount of things that appear on the skin that are related to obesity also. Now, acanthosis nigricans is pretty easy. I mean, all of you know that. And the reason for this is all of us know that insulin is a blood sugar regulator, but it also has growth factor potential as well, so stimulating the skin to grow. And you see the skin tags on the interior neck as well. Tend to see both of them together. And, you know, discouragingly for our type 2 diabetics, also has some tumor stimulating factors as well. So there are some dangers, aside from having blood sugar out of control, of having high insulin levels. So when I see this, I can pretty well bet that for the most part, their fasting blood sugar and their hemoglobin A1C is probably going to be normal. But if you check an insulin level, that will usually be elevated. So I like to make sure that insulin level is collected with that, because I think some of the kids get a little bit of a false sense of security when their hemoglobin A1C and their blood sugar is normal. So all of you know acanthosis nigricans. Now what you might know is there are some locations for this that are a little bit less than classical. So brachial fossa, back of the wrist, and knuckles, you'll see this a lot. So that's very revealing, I think, to the teenagers. Say, you know, that little dark spot on the back of your knuckles, that's related to the same dirty spot on the side of your neck and under your arms. And even on the lips, you know, it can get kind of thickened in the corner of the mouth. But this I'm bringing up isn't really an association with obesity so much as it's a acanthosis nigricans look-alike. And actually just saw somebody with exactly this and exactly this location just yesterday morning. So these are kind of fun because it looks like acanthosis nigricans, and it's in a concavity, but it's not really the side of the neck the same way. And this, you can just take an alcohol pad and wipe it away. I mean, there's nothing I see in the clinic that within 15 seconds I've cured someone. And it's a little embarrassing to the parents, but this we kind of give the whimsical name of terra firma, or retained keratin is a little bit more reasonable medical sounding name. But you cannot wash that off with soap and water, no matter how you scrub it. But it's highly, highly soluble in alcohol. So just take an alcohol pad and wipe it away. It's really a fun thing to treat, even though parents kind of cringe after you do that. But this is associated with obesity. So classic female of color is generally where I'll see this, and it's a little bit reticulated through the abdomen. You see here a little bit verrucous, almost a little rough or hyperkeratotic, a little bit more confluent in the armpit, so it's confluent and it's reticulated and it's slightly papillomatous, so I'm kind of leading you towards the name here. It's confluent and reticulated papillomatosis, and if you really want to give somebody a mouthful, I enjoy telling teenagers this. You can go back to school and say you had confluent reticulated papillomatosis of Gougereau and Carteau, or CARP is what we tend to call this. Now, over the past decade, there's been a little bit of a transition, and I don't think I see anybody with CARP anymore that isn't overweight and doesn't have acanthosis nigricans as well. So it's a distinct association. Now, the pathogenesis is different because the things that we treat CARP with very successfully don't really make the acanthosis nigricans go away, but there's a definite association there. So it's usually teenagers, usually people of color, and usually female, but not everybody fits that exact stereotype. And usually not terribly symptomatic, maybe a little bit of itching. And again, these reticulated hyperkeratotic areas that tend to coalesce in some areas. Exactly why this occurs is unknown. There might be something associated with insulin resistance or obesity that fosters the growth of either bacteria or yeast. It probably has something to do with bacteria, because minocycline has clearly become the treatment of choice for this. And usually it's a diagnosis clinically. It's very seldom something that I have to biopsy to be able to figure out. And I know you can't read it, but this is the main point there. Even though there's this long list of things, which usually means nothing really works well, minocycline works really great for this. So I do 100 milligrams twice per day. Doxycycline probably works well, but minocycline is what's kind of come down through the literature. And it usually just melts away with some potential for recurrence. And I might add like a salicylic acid soap wash to this also. And just to show that not everybody fits the stereotype, a guy who's Caucasian definitely can happen. And you know, the other thing is associated with obesity. When I started my practice in pediatric dermatology 32 years ago, it was really rare to see hidradenitis suppurativa. Now I'm showing you a picture that's just grotesquely terrible to illustrate the condition. And now a month doesn't go by where a teenager doesn't come in with this condition, and it's almost certainly related to the obesity epidemic among teenagers. Really horrendous condition. So what's new with this? This is kind of like the list of things that we have available for treating hidradenitis suppurativa. But, you know, with the IL blockers, IL-17 blockers, we really have a medication that works pretty stinking well for this. So we're finding ourselves doing less surgery and more aggressive but less effective treatments for this. So that might be new to you as well. Losing weight, stopping smoking are all reasonable things to do as well. But where it's been a very, very, very difficult condition to treat, we have decent treatments now. To a point, actually, if I send somebody to surgery, they probably would not do any surgery on it until they've been on an IL-17 blocker. And then, you know, as if being overweight isn't bad enough, this is kind of hot off the presses from the American Academy of Dermatology, but probably there's a very pro-inflammatory and even autoimmune component to being overweight, so that autoimmune conditions are more common in people who are obese, And in my world, psoriasis is a really great example of that. We definitely see psoriasis much more frequently in people who are overweight, and it's more difficult to treat. So that's skin and obesity. I'll keep moving it, there's no questions. Medications, we'll spend a fair amount of time on medications. Now, this is not brand new, but in my career, in 32 years of practicing pediatric dermatology, nothing comes close to the revolutionary aspect of using beta blockers for hemangiomas. Nothing has altered the way I treat any condition more than this discovery. So it all started back in 2008 with this New England Journal article as a pure accident. You have a child with a hemangioma treated with prednisone, which sounds archaic. It sounds almost medieval now that we treated people with prednisone for hemangiomas. Developed a cardiomyopathy and was placed on beta blocker, propranolol, and the hemangioma just melted away. And the doctors were smart enough to put 2 and 2 together and think, well, maybe there's something therapeutic here. And the explosion happened from there. And so this has provided a really spectacular way of treating hemangiomas in a infinitely safer way than we ever had before. Far and away the greatest innovation in pediatric dermatology through my career. So it's a little hard to believe, but in 2008, 2009, 2010, when we were just kind of getting going on this, pretty much everybody we started on propranolol, we were admitting to the hospital. Hey, you know, the cardiologist would call and say, what on earth are you guys doing? I mean, this is just propranolol. You're not going to kill somebody with this medication. So, you know, then we started, you know, with otherwise healthy kids, you would start them at 1/3 of a dose and then 2/3 of a dose and full dose, and you'd go to the pediatrician, get your heart rate checked and all that sort of thing. This is relatively hot off the presses, and Albert Yan, who's at Children's in Philadelphia, is a good friend of mine, has been kind of leading this ever pushing the envelope of starting propranolol to a point where they just do it full dose. So this study looked at the kiddos retrospectively that they started on half dose, those that they just blasted right with full dose, 2 milligrams per kilogram per day. And there was no difference in any complication. They had a few that had what they called significant drops in heart rate and blood pressure, but not symptomatic. So this has become my norm now. Eczema, the bane of my existence. You know, about 20% of the entire pediatric population has eczema or some atopic tendencies. So this is my everyday of seeing really terrible eczema. So, you know, number 2 to propranolol has really been the development of dupilumab, Dupixent for atopic dermatitis. These are some of the most miserable kids, and as you can imagine, some of the most miserable families that I take care of. And for the most part, we can bring them under pretty decent control. Treating atopic dermatitis is my next thing with resident conference. It's a whole hour in and of itself. But you do get this population that you just cannot get better no matter what you try to avoid, no matter what you treat them with. This is absolutely miraculous. It's a really wonderful medicine. I wish it didn't cost $35,000 a year, and that's going to be a common theme with many of the medicines that we'll be talking about. So at this point, this is kind of old hat. I mean, we've had Dupixent for years now, and it's FDA approved down to 6 months of age. So it's not so new. What is a little bit more thought-provoking is we know how to put people on it. We know who to put on it. What we don't really know is, okay, you've been clear for a year. Now what? Are you going to be on Dupixent like when you're 100 years old, carted off to a nursing home? Or, you know, is there some way of getting off of it? So this is in the adult literature. But intuitively, if you were going to think, how would I do this? Well, you'd probably spread out the dose, which is exactly what they did. And the results were really pretty significant. When you looked months down the line, if you, whatever score you use, like EASI 75 or an IGA score is kind of a clinical easy assessment, they did just about as well coming off the medicine as they did on it, or tapering it down or spacing it out. So it's kind of intuitive, but it's nice to have something empiric to fall back on to say, yeah, that's a reasonable approach. So I'm totally used to putting people on dupilumab. I'm just barely getting used to the point of how do I get them off of it. You may or may not know, with a lot of these medicines, you're really not supposed to give live attenuated vaccines. But is that absolutely necessary? You know, in the clinical trials, you had to stop Dupixent well before giving live attenuated vaccines, and you had to wait a while afterwards. Well, as you can imagine, in the clinical trials, there were some accidents, you know, that kids did get live attenuated vaccines while they were on it. And this is kind of a compilation of those accidents. And in a reassuring fashion, none of them had any bad reaction. Now, what you don't know is, was there a blunted effect of the immunization? So maybe it didn't take as well, but at least nothing bad happened in this case. And I think we probably will see some alterations in immunization practice for kids who are on dupilumab, because IL-4 and IL-13, which is what this blocks, really doesn't have an immunosuppressive effect, which is one of the great aspects of this medicine, is the kids, it does affect their immune system, but it doesn't immunosuppress them, which is fantastic. And in sort of an unrelated study, there was a population in adults, in this case, that were on dupilumab, and a wave of yellow fever went through. And they did immunize them to yellow fever, even though they were on dupilumab, and they did seroconvert well. You know, that's indirect evidence, but it's at least some encouragement that you can immunize without side effect, and you can immunize probably with a decent immune effect. Alopecia areata, I mean, these are healthy people, but their hair's falling out. Is that a big deal? Well, if you ask Chris Rock, it probably is a little bit of a big deal. But, you know, these are not happy patients. So if there's something that you can take, particularly very severe, significant hair loss, and make it better, that would be a good thing, particularly for those that lose really significant amounts. So this is, you probably have heard, either through television commercials or through journal articles and such, the JAK inhibitors are starting to become the thing for treating alopecia areata, but they're expensive as stink. So this review kind of caught my eye of looking at pulse steroids for treating alopecia areata. I can't say that I relish this, but it's reasonably effective. You know, 50-ish or so response, which doesn't sound spectacular, but as we look at the really expensive medicines, not much better than that. So this is something that I keep in mind with somebody that's just really eager to treat their alopecia areata, but doesn't have insurance coverage and isn't going to pay for a JAK inhibitor. So these are pulse. Most of them were monthly. I tend to do like a little bit lower dose and do it weekly. But I have to preface this as something I'm not really fond of doing one way or the other. The last thing in the world I want to do is take a healthy pediatric patient and put them on medicines that I'm going to worry about their health, even if it is pretty significant in their life. And then just to review a little bit, you know, the two articles that I'm quoting here were nice reviews of what really has become kind of a dizzying array of articles on JAK inhibitors for alopecia areata. Now, what's become really apparent is the holy grail of a topical JAK inhibitor just does not work. It's got to be systemic. That was really, really disappointing. And the trials are showing that the JAK inhibitor is better than placebo, but still not spectacular. And there is at least one agent that's FDA approved down to 12 years of age. So, I mean, a little bit of a busy slide. But if you look at a score, a SALT 20 means they've grown to about 20% loss, 80% regrowth. So that's kind of a reasonable mark for most of the clinical studies. And it's in the order of about 50% or so. If you look at a reasonable endpoint, we'll get to that point. It's expensive. It's in the several tens of thousands of dollars for a year. It's not disease modifying. So if you stop the medicine, the hair will come back out again if that's what destiny had in store for it. And there's some evidence that people are more depressed when their hair falls out the second time than they ever were the first time through. So you wonder if you're really doing somebody a favor with this. I only have a few patients that I've treated so far, really hard to get covered, and I don't do it with great enthusiasm. Now, just as an aside, because this isn't pharmaceutical, but this you can tell is male pattern baldness. You think, now we're pediatricians, I mean, how much male pattern baldness do we take? This is really just kind of hot off the presses, actually not even published yet. But looking at it's a multi-center study over a long period of time, and it's not a lot of patients, so it does tell you that if it took a load of big institutions over 20 years to come up with 203 patients. This is not super common, but what was really sobering to me with this is that the mean age was about 13 years of age. Staggering. And if you take like the standard deviation, even down to 10 years of age. So it is something that can happen at a very, very young age. And a little bit of a preponderance of males, but not as much as you'd think. It was roughly 50-50 males and females. And we've got all sorts of treatments that we have for this now. This is another thing I do unenthusiastically. Topical minoxidil, I think, is still the first line. But we're starting in dermatology to use oral minoxidil more and more. And Propecia has been around for ages as well. So we do have some decent treatments, and for females, we'll sometimes do more hormonal treatment because this might be associated with polycystic ovaries and such. Vitiligo, in my patients of color, this is one of my Honduran patients, if it's on your face and you're a person of color, this is really significant. So if there's something that might be able to help this, that would be a great thing as well. So you might have seen television commercials for this as well. Opzelura is the brand name. And it's FDA approved down to 12 years of age. And, the improvement's not terrible. If you take 75% improvement, if this was you or your patient, 75% wouldn't be bad. It wouldn't be perfect, but it would be an improvement. It's about 50% of people will reach that endpoint. It's not systemic, it's topical, that's pretty good. That's a pretty decent result, but a 60-gram tube of this is $2,000. Pretty stinking expensive. And as you can imagine, not easy to get through insurance. And the same can be done with atopic dermatitis. So again, decent results, whatever scoring system you're using, whether it's an EASI score or an IGA score, pretty decent results with mild to moderate atopic dermatitis or moderate atopic dermatitis with an incredibly expensive medicine. It's nice that it's not a topical steroid. Doesn't burn quite the same way as some of the other non-steroid agents that we do. But again, $2,000 for a tube, this is probably not going to catch on. And frankly, mild to moderate atopic dermatitis is not where I run into problems. I can pull out triamcinolone or a little bit higher steroid, burst it for 2 to 3 weeks, do it weekends. I can take out ultraviolet light and get most of that group better. But I don't need a $2,000 premium necessarily to fit that bill. And sometimes with some of the medicines we come up with, or the pharmaceutical industry comes up with, just seems to be like a Rube Goldberg sort of like complicated and expensive way of solving a relatively simple problem. And I don't think there's any better example than treating mollusca contagiosa. Now, all of you see this. I mean, every kid on the face of the planet gets mollusca someday, whether they realize it or not. And I'll tell parents, I see thousands, literally thousands of kids with mollusca. Never ever does a parent roll up their sleeves and say, look, I caught them too. It's good proof that something that's highly contagious, you've been immune to for 30 years or so. So everybody gets them. They all self-resolve. So this is a study that I'll quote fairly frequently. And this is, again, it's not cutting edge. This is 10 years old. Looking at just retrospectively, it's not a controlled trial of this group we're going to randomize here and this group here. It's just retrospectively looking at kids with mollusca that were untreated versus those that were treated with a lot of different mechanisms. And the results are pretty sobering. If you look many months down the road, the kids who were not treated ended up pretty much exactly the same as the kids who were treated, except for they weren't terribly traumatized by the terrible things that were prescribed to them. So this is something that I kind of fall back on when a parent wants to be aggressive with treating mollusca. And if I can get out of the room with no treatment, or maybe a low-dose topical steroid to help with some of the secondary inflammation or the eczema that goes along with it, that's magic. I'll parenthetically say that the exact same study has been done with regular human papillomavirus warts as well, with pretty much the same results. The treated group, not much better off than the untreated group. So new treatments. This you might have heard of, this berdazimer gel. It's kind of a nitric oxide releasing gel. And a lot of my colleagues in pediatric dermatology have been involved with these studies. So if you look at the p-value, 0.001, that's pretty impressive. If you look at the numbers, not that impressive. You know, so 30% versus 10% for placebo. This has not hit the market just yet, so I don't have a price on it. I'm going to guess it's going to be real expensive for treating a condition that's not that bad with a cure rate that's pretty marginally above placebo. So that's kind of like my Rube Goldberg sort of thing. Now, I think something we will see fairly soon is this newer treatment with cantharidin. Now, I've been using cantharidin my entire career. We used to get little bottles of it, you know, snuck over the border from Canada. And, you know, I could treat probably 30 patients with one bottle. And I don't love treating them with cantharidin. It doesn't hurt when you put it on, which is great, but then you send them home to develop a blister, and the parents are really kind of stuck with the burden of wound care and that sort of thing. But it was inexpensive. It was something you could offer that wasn't terribly traumatic to kids. Now it's really hard to get the stuff from Canada. I don't have anything in the clinic for cantharidin, but this new FDA-approved cantharidin form, YCANT, is available. So now you can write a prescription for it. Parents can go to the pharmacy. It's not for self-application. They got to come back into the clinic and you can apply it, and it can be done repetitively. And you know, clearance beats placebo, but it's still 50%-ish or so with multiple treatments, and it's expensive. You know, I don't think a price has really been determined for this yet. I called actually yesterday out of curiosity. I called CVS to see, is this available and what does it cost? And he said, well, you know, this is a specialty pharmacy thing. It doesn't come through the regular pharmacy. So that kind of tells you right off the bat, this is going to be expensive, whatever it's going to be. My guess is probably about $600 to $800 for a tube of it. Now, there's some things I like. It's colored, so you can kind of tell where you put it on. So that's kind of nice. It's FDA approved. So I was doing a non-FDA approved treatment all the time I was using cantharidin before. And it comes with a lot of detailed patient information, which is really kind of nice. And, you know, if you look at their advertisements, even help with pronouncing it. So if a parent's struggling, mollusca contagiosa, the little mollusca guy can help you with that as well. You know, what I really don't like, or what worries me about this, is that in the media, mollusca are going to start to get villainized. You know, if you don't treat this, your entire family is going to get them, and the little guy's even going to knock over the blocks that you're setting up. So, you know, I've made a career of trying to talk people off the ledge of treating mollusca, and now it's all going to come crashing down on me with this kind of media blitz that I think is probably on the verge of happening. Again, it's going to be expensive. I don't know how expensive, and I'm not sure if it's going to get covered or not. But I'm worried that there's going to be some demonization of some of the simplest things that we've done. And even, you know, over-the-counter salicylic acid that we use on human papillomavirus warts, that were okay for mollusca. $7 for a bottle of that. You know, I'm just not sure we're heading in the right direction here. Just parenthetically, some of you might prescribe Aldara or Imiquimod for warts. This was a study that was kind of requested by the FDA that 3M do on mollusca, and it was just barely equal to placebo. And there are some negative effects of using Imiquimod in terms of like cytokine storm and so forth. I don't use Imiquimod at all for mollusca. Now, you know, mollusca, alopecia areata, vitiligo, perhaps not the most important diseases that we'll treat as pediatricians, but while it's rare, epidermolysis bullosa is a bad thing. These are some of the most desperate, pathetic patients that I take care of. Really, really, really life-altering. So if there was something that could be done for these poor kids, that would really be spectacular. So this is a study looking at oh geez, where's that mollusca guy when I need it? Buramagine Gaypervec. I'm just going to go with BVEC, which is a lot easier to pronounce. But this is really interesting technology of where you get an inactivated herpes virus to transfer the gene that's missing in this condition, in this case type 7 collagen, not infecting them with herpes virus, but enough to inject the DNA that they're missing. Just spectacular. And you wonder how generalizable this might be to any skin or mucous membrane condition, gastrointestinal, respiratory, and such. So really neat technology. And it works pretty well. But this is a copy of an email that I got while I was at Geisinger from the pharmacy that works with our health plan, Geisinger Health Plan. And you don't need to read the whole thing, just look at what's in big print. A year of treating somebody, of one patient, over $1.5 million. So this has got a ways to go before it hits the mass market. Now, fortunately, this is a recessive dystrophic EB in particular is relatively uncommon. And any miracle for something that's that life-altering is welcome. You would hope it would be a little less than $1.5 million per year. So, in short, if we sum up what's going on with medications, we've got a lot of diseases that the pharmaceutical industry is really helping us with, and that's really great. And I'm thankful for that. I just don't know where the American health system kind of absorbs the cost of some of these things. And I really wonder if there's an unsustainable crash coming in pharmaceuticals. Now, that's just my world in dermatology. If you look at oncology, rheumatology, gastroenterology, all these specialties have their own sort of like mix of pharmaceuticals that cost a fortune. I just don't know where this is all going. So isn't it cool, that an article came out last year just sort of revisiting something as simple as petrolatum. Now, parents will ask me, particularly with my age patient, what's the perfect emollient? Chemical-free, really thick, really cheap. You cannot beat Vaseline petrolatum for treating any dry skin condition. Now, a lot of people don't like the texture and so forth, but isn't it great that a lot of the things that we might have worried about, it's a petroleum product, is it carcinogenic? It's not carcinogenic. It's non-allergenic. It's as chemical-free as anything you could possibly imagine. Isn't it going to clog up the pores if somebody with acne uses this? It is not comedogenic. It's not flammable. If you think it's a petroleum product, it ought to go up in smoke. It does not. Is it safe in preterm neonates? Yeah, it's been proven safe there. You might think back of a study from about 20 years ago where preterm neonates had an increased risk of Candida infections when they were treated with petrolatum, but the comparison groups were not the same. The petrolatum group was much sicker than the other group. So that's been disproven. And for about 38 cents an ounce if you order it on Amazon. I'm going to finish off with just some things related to infectious disease. Talk about viral exanthems. We tend to talk about a viral exanthem. This is like the classic maculopapular rash. I think that's why pediatricians describe everything as maculopapular, because that's the majority of what comes into your clinic. But the other adjective that we'll use is morbilliform, which is not necessarily something that conjures up an image in your brain or to even know what it means. Well, morbilliform is Latin for measles. So a viral exanthem looks morbilliform. Well, if you've never seen measles, it's not exactly the best adjective in the world. Probably better to say, what's a measles rash looks like? It looks like a drug rash. Now you're conjuring up an image of what measles looks like. Well, why even talk about it? This is a viral exanthem. If it was an adult, you'd probably call it a drug rash. Macules and papules. That's why it's maculopapular. But, what does measles look like? The 3 C's on this of cough, conjunctivitis, coryza on the skin or the mucous membrane, the complex spots, and then the exanthem that starts from the top and works its way down. Why even talk about this? measles, exanthem, the complex spots. I don't have pictures of this because I don't know that I've seen a case of measles in ages. We're starting to see this. This was outbreak in Disneyland, not Disney World, Disneyland, several years back. But if you've been following the news at all, I mean, these are numbers that I just picked up off the internet like 5 or 6 days or so ago. It's this outbreak of measles. And it hasn't yet happened in Virginia this year. But if you look at 2024, there were several cases in Virginia, several outbreaks in Virginia. So I'm preparing myself because I'm sure at some point I'm going to see a case of measles, and I'm just going to call it a viral exanthem.
I think there was a case in Northern Virginia just very recently.
Seriously?
Yeah.
Okay, it's coming. So I'm trying to mentally prepare myself so I don't blow off every viral exanthem that I see as either a drug rash or just, a virus, and try to be a little bit more specific with this and think, maybe it's measles. And unfortunately, a couple of deaths associated with this as well, which is really tragic. Scabies, you probably all see scabies from time to time. I have a strong preference for proving the diagnosis before I see it. And the KOH scraping, I think, is the gold standard. When you see one of those little buggers on the other end of the microscope, there is no doubt. And there are a few things that we diagnose, I think, in medicine in general, where you can say, I am sure of what this is, indisputably. But you don't have access to a microscope and being able to do KOHs. So this study caught my eye of using a Woods light, and you probably have that hanging around the clinic for looking at white spots and that sort of thing, for highlighting scabies burrows, which can be really hard to find, in people that are scratching. And it just doesn't show up on the screen as well as I'd like, but I think you can kind of see these little squiggly lines. Now, these are examples of somebody that are just polluted with burrows, so, it makes for a nice illustration. So I actually bought, a little handheld Woods light so I can have it in my pocket or my exam room, and saw somebody yesterday on my schedule, it said possible scabies. So I was just dying to pull this out and give it a try, but it actually wasn't scabies. But a dermoscope is actually not a bad way of doing it as well, which is non-invasive and doesn't require scraping and a KOH and such. And you can actually see the burrows and the mite. Even with a good magnifying glass, you can actually see the mite at the end of the burrow. And I think that helps to actually have the diagnosis for sure. A little bit sobering. Now, this is Europe, so probably not in the United States just yet. But this was looking at benzobenzoate compared to permethrin. Permethrin is our standard of care. They do 3 days in a row, which isn't quite the same as our treat it once and then treat it in 7 to 10 days or such. But just the same, the cure rate with permethrin was only about 27%. If it's happening in Europe, it's probably not that long before it's in the United States. So that to me was not good news. A new fungus, perhaps you've heard of this, and I think this is another thing that we're probably going to see before too long. Trichophyton I got this one, mollusca guy, Indotinei. So most of the reports out of Central Asia and Southeast Asia, China, and such, but a highly, highly, highly resistant form of trichophyton. And a couple of things that are difficult with this is that it probably, if you send a study to our lab, they will probably just read it as trichophyton. You will not get an indication that it's this resistant strain. And the only indication you'll get is that the treatment that should work, usually terbinafine, is having no effect on it at all. So, and initially in Asia, a few cases reported in the United States, and now multiple states in the United States. So I've kind of relied on the American Academy of Dermatology's website to kind of update on this. So it's becoming a bit more prominent. And again, it's hard to identify. It will not necessarily strike you that it's different than just regular run-of-the-mill trichophyton, which responds really nicely. So you would have to ask the lab to do special studies, particularly polymerase chain reaction, to be able to identify this. And again, griseofulvin and terbinafine are not very good for it. It seems to be sensitive to itraconazole, which is not high on my list of antifungals to go to, and very limited efficacy to fluconazole and ketoconazole. So this is very, very recent, some cases out of China. some clues that it's an unbearable itch. Now, nobody likes having fungus all over their body, and they're probably going to complain of itch, but this is like an unbearable itch. And a lot of hyperpigmentation. So I've got some pictures that I kind of got off the internet. And the other clue is that they're just not responding to pretty significant, usually good treatment. So a little bit more hyperpigmented and very extensive and itching like a son of a gun. So that's trichophyton indotinea. I think we're probably going to be seeing it at some point, but it hasn't crossed my table yet. And then just regular old tinea capitis. In people of color, I have a hard time with this. Now, you have to admit, I'm not seeing it as much here as I did at Geisinger, because it might be I just don't have as much of an African population here just yet. But distinguishing this from seb derm can be really challenging. So I generally will culture. Now, in this little guy, you can see he's got a postauricular node. That's a pretty good clue that it's fungus as opposed to being seb derm. But my norm back in Geisinger was just take a toothbrush and kind of rub this, put it back in its wrapper, and send it to microbiology. I got here, and it's like I was from another planet when I mentioned that to the microbiologist. Now, to their credit, they didn't totally poo-poo the idea, and we've been able to pursue this. And actually, it's taken off a little bit. I thought, I'll call them, I'll send them some articles on toothbrush, and naturally, because it's me saying it, they will accept it on my word. So we are giving it a trial, but somebody had the idea of, well, if we're doing it, why don't we gather some data? So, okay, I'll set up a spreadsheet. If we're gathering data, we probably ought to publish it. So now I'm going through the IRB. So this is really kind of like mushroomed a little bit, much more than I hoped at a friendly phone call of doing a new technique. But, if you've got a toothbrush, you can get a fungal culture. And it's hard to tell which one's which here, but the results that we've had so far are really exuberant fungal growth with the toothbrushes. And we're kind of doing it dual with the age-old technique of scraping it into like a urine bottle or something like that. And they've both been positive. But the ones that we do in the classic technique of scraping it into some kind of container is nowhere near as vigorous and obvious as with the toothbrush. And it is so easy. If you've got a wiggling 2-3-year-old kid, coming after them with a scalpel blade to get scale is nerve-wracking, to say the least. So you can do this now. If you send down a toothbrush, microbiology will not reject it on spot. They will be able to accept this. Coxsackievirus is a little bit different. This is the coxsackievirus I grew up with, late summer into the fall, in the mouth, on the palms, and so forth. That's not the way it is now. I mean, in fact, it's almost abnormal to see normal coxsackievirus nowadays. Now it's much, much more the Coxsackie different strain that doesn't necessarily involve the palms and soles. And unfortunately, the kids are not quite as sick as they were with classic Coxsackie Eczema coxsackium is probably a term you've heard. It looks for all the world like eczema herpeticum. In fact, we've admitted kids to the hospital for acyclovir therapy for this. Cultures come back negative, and you think, what on earth? This can't possibly not be eczema herpeticum, it's eczema coxsackium. Much more hemorrhagic purpura and blisters on the feet. Big purpura. Crosty-like rash. But this is probably the most telling thing in my mind of the atypical coxsackie is these papules around the mouth as opposed to inside the mouth. And you've probably all been seeing the onychomydesis. I love this because I can look at kind of the Bose line here. So the nails separate proximally, but there's a line right there. Nail takes about 6 months to grow from back to front. That's about 1 month. So I'll say, oh, you had hand, foot, mouth a month ago, didn't you? And Mom's like, how on earth did you know that? Well, that's like so characteristic of hand, foot, mouth, that onychomydesis there. All right, I'm going to stop here. One of the things I was going to talk about is sort of new nomenclature of genetics versus morphology. And probably the best example for me here are the PIK3CA or the vascular malformation syndromes. And I'm not going to talk about this except for that. We have an expert in vascular malformation syndromes coming for Pediatric Dermatology Grand Rounds in May. I think a notice went out to all of you. You're all invited. I'm really excited to have my friend Beth Drolet coming. She's an excellent speaker, really knowledgeable, and that will be on May 2nd, Friday, May 2nd, and starting at 1 o'clock in our conference room on the 4th floor of Riverside 1. All right, I think I've gone as far as I need to. You're starting to glass over a little bit. Thanks for coming.
Thanks so much.
Can I just ask, what do you do with the Carilion? Are you, like, do you do a dose of steroids or?
Yeah, it's a good question. They're hard to diagnose, number one, because you're pretty much relying on a clinical diagnosis. A lot of times they don't culture, and they're impossible to get a KOH off of. I mean, the kids are really tender, and you can't get near them. But fortunately, it's a fairly easy clinical diagnosis. So usually you're on the right track there. 95% of the treatment is antifungal. If you remove the fungus, then that vigorous immune response goes away. If you treat with prednisone, you bring down a little bit of the inflammation, but you do affect some of the body's ability to be able to fight the fungus well. So I don't routinely do that unless somebody's stubborn. I didn't really touch on this very much. Knowing the organism is really helpful. So I do rely on culture. I realize you can move forward with a clinical diagnosis. And if there's a dog in the family that's affected, you probably know that it's Microsporin camus and not trichophyton. If they're a wrestler, it's probably trichophyton. But usually you don't know. And it makes a big difference. If you're dealing with Microsporin, you're 3 months into treatment with that. And terbinafine will not work. If it's trichophyton, you're more in the order of 6 to 8 weeks, and terbinafine will work. So I think knowing the organism is really important. Oral antibiotics too, they're usually secondarily infected. I don't do that either.